All right, we'll go ahead and get started. Welcome everyone to Cardiology Grand Rounds. We're delighted to have a group of distinguished faculty from our division present at Grand Rounds today on their approach to pre-transplant cardiovascular risk assessment. So we have three speakers today. I'll introduce them all briefly. They'll all give their presentations and we'll take questions and discussion at the very end. Our first speaker is Dr. Anagnostopoulos. She is an instructor in medicine at Harvard Medical School. She's also the Director of Recruitment and Advancement of Women Fellows in Training for our division. She sits as a counselor at large for the American College of Cardiology Massachusetts chapter and is also very involved in our Advancement of Women Committee for the Department of Medicine at BIDMC. Our second speaker will be Dr. Ariane CoCo Fraiche, who is also an instructor of medicine at Harvard Medical School. And our third speaker will be Dr. Michael Gavin, who is an assistant professor of medicine, as well as director of our Cardiac Direct Access Unit at BIDMC. In addition, Dr. Gavin also serves as the medical director of FAR 5 and directs our inpatient cardiology nurse practitioner program. So we're really delighted to have this group of three distinguished faculty speak to us today about pre-transplant evaluation. So go ahead, Dr. Anagnostopoulos.
Thank you, Arti, for the kind introductions, and thank you also to Rob and Peter for inviting us here today to talk about the work that we've been doing. Today, Mike, Coco, and I are going to talk about the clinical program we've been involved in developing with the kidney and liver transplant teams over the past 5 years. Specifically, how do we evaluate cardiovascular risk prior to solid organ transplant here at Beth Israel Deaconess Medical Center. We have no relevant disclosures. Today, we hope you will take away a number of learning points. Specifically, we aim to recognize the role of a dedicated cardiovascular risk assessment program at a kidney and liver transplant center. Next, we hope to help you understand the limitations of traditional cardiac risk assessment in this particular patient population. We aim to describe our multimodality ischemic risk stratification approach here and review how we currently optimize this patient population prior to transplant. Lastly, we'll identify areas of improvement and future directions of this work. And given time constraints, this discussion is not meant to be an exhaustive review of all different types of cardiovascular disease that we see, but we will primarily focus on coronary artery disease and its related risk. The first question you may be asking is why even have a dedicated group of cardiologists that routinely assess cardiovascular risk in this patient area, and why do we adjust our approach beyond the typical perioperative risk assessment that we are all familiar with? Well, solid organ transplantation involves allocation of a scarce resource, and therefore the aim is for the best possible long-term outcome beyond a more traditional 30-day periop morbidity and mortality that we're familiar with. Moreover, solid organ transplant programs report their outcomes publicly to the Organ Procurement and Transplantation Network. Programs are monitored as to whether they fall within or outside of an expected outcome compared to other institutions. And at BIDMC in 2015, the 1-year kidney transplant survival fell below an expected outcome within a 2.5-year reporting period. And when these cases were further evaluated, the transplant program recognized that a significant number of deaths within the first year were cardiovascular related. And in fact, cardiovascular death remains the leading cause of death in kidney transplant recipients at 1 year. This was an analysis of 90,000 first-time kidney recipients from 1996 to 2014. And here the blue plot shows that when the cause of death was identified, that cardiovascular death remains the leading cause. And also as part of this internal review, a number of other contributing factors were identified. Firstly, varying approaches to cardiovascular risk assessment was noted among cardiology specialists. And this also included cardiovascular risk assessment done both within the institution as well as outside centers. There was an inability to do quality control on cardiovascular testing, and they found themselves having to rely on written reports as opposed to reviewing primary data. And this led to the question as to whether they could protocolize a cardiovascular risk assessment in order to mitigate some of these cardiovascular events post-transplant. And therefore, there were initial discussions between nephrology and cardiology. And then in 2017, the first BIDMC multidisciplinary summit took place that brought together transplant nephrology, transplant hepatology, transplant surgery, and cardiology with the goal to more systematically address these concerns and design the first iteration of a BIDMC protocol. First, we will start with a case. This first case is a 50-year-old woman with end-stage renal disease on hemodialysis for 6 years. She has a history of hypertension and hyperlipidemia, as well as HIV on antiretroviral therapy. She's also a former smoker who quit 2 years ago and is referred for preoperative risk assessment prior to kidney transplant. She has no anginal symptoms, normal functional capacity, and a non-ischemic ECG. And so how do we approach this patient's cardiovascular risk in this setting? First, it's important to understand that the significant burden of cardiovascular disease overall in patients with chronic kidney disease. 50% of patients with chronic kidney disease, stages 4 and 5, have cardiovascular disease overall. And cardiovascular mortality accounts for 40 to 50% of deaths in advanced CKD, compared to 25% in the general population with normal kidney function. And here is just a depiction of the many interactions between vascular disease, heart failure, and chronic kidney disease that are thought to contribute to the progression of cardiovascular disease and influence the prognosis of these patients. And here we get to the real crux of the issue, which is that cardiovascular mortality in patients with end-stage kidney disease is markedly increased compared to age-matched controls without kidney disease. So as you can see here, a young person on dialysis has an annual mortality that is 500 to 1,000-fold higher here compared to someone not on hemodialysis. And that young person's mortality corresponds to the predicted mortality of an 85-year-old without advanced kidney disease. And so as you can see, we're trying to optimize long-term survival in patients that are already at markedly elevated risk of cardiovascular death. In 2012, the ACC did publish guidelines on this topic, and for kidney transplant candidates, they identified a number of risk factors that we're all familiar with here. They included diabetes, known cardiac disease, more than 1 year on dialysis, LVH, age greater than 60, smoking, and then hypertension and hyperlipidemia. And they made the recommendation that non-invasive stress testing in these candidates with no active cardiac conditions could be considered if there were 3 or more risk factors present, regardless of functional status. And there are some studies that have looked at this issue, mostly retrospective. In this relatively small observational study from 2011 at Mount Sinai in New York, they retrospectively looked at a large cohort of kidney recipients. And I'll just highlight a couple of things in this busy slide. Firstly, the vast majority of patients that were screened were asymptomatic, and almost half of the patients who were asymptomatic and went on to have an abnormal stress test and then a subsequent angiogram showed no obstructive coronary disease. Also, about 20% of patients were screened and went directly to angiography, and 75% of those were also asymptomatic. However, of those, 50% had no obstructive disease, but up to 25% had 3 vessel disease as well. And overall, they demonstrated that there was a high burden of coronary disease in this patient population. They also reported sensitivity and specificity of stress testing in this patient population and found that the sensitivity was quite modest. And lastly, I'll just point out that revascularization was performed in a minority of asymptomatic patients at this institution. Okay, so back to case 1. We clearly have a patient with multiple risk factors for cardiovascular disease. And so the guidelines would recommend stress testing in this scenario. And so she did indeed undergo nuclear perfusion stress testing, which was normal. And so really the question for us becomes, is this test really good enough to understand this patient's coronary artery disease burden and whether we could be missing in an already high-risk patient occult high-risk coronary disease, given the overall low sensitivity of stress testing in this population? And we will come back to that. And so what about liver transplant candidates? Again, we have a case. Case 2 is a 61-year-old man with end-stage liver disease due to alcohol cirrhosis. He also has hypertension, type 2 diabetes on insulin, and hyperlipidemia. Has relatively normal functional capacity and presents for preoperative risk assessment. He's already had a nuclear perfusion study, which was reported as normal, as well as an echo with normal LV systolic function seen here. And so more generally, overall cardiovascular mortality in patients with end-stage liver disease is lower than that of patients with advanced kidney disease. And again, in a retrospective analysis that was quite large of liver transplant recipients, 32,000 patients between 2002 and 2011. Overall, in this time period between 2002 and 2011, they found the 1-year mortality of liver transplant recipients was relatively high at 12.2%. But they also looked at major adverse cardiac events relatively early after transplant, 30 days and 90 days. And they defined MACE in this study as pulmonary embolism, atrial fibrillation, which actually had the largest proportion of MACE at 43%, cardiac arrest, heart failure, and myocardial infarction. And so overall, they found that patients with an early MACE event had overall lower 1-year survival compared to those patients who had no event. So specifically, it was 79.1% survival in the MACE group and 88.4% in the no event group, and that was statistically significant. And then they also looked at long-term survival beyond 1 year in those two groups and showed that those with a 30-day and 90-day MACE event had worse long-term survival. And here I'll just highlight the fact also that atrial fibrillation has been identified as an early adverse cardiac event. And AFib has come to be thought of as a marker for under-recognized cardiovascular disease and cardiovascular risk in the liver transplant candidate population specifically. Again, just referring back to the 2012 guidelines, the ACC did address liver transplant evaluation as well and recommended non-invasive testing for patients with 3 or more of the following factors. Again, diabetes, known disease, LVH, hypertension, age greater than 60, smoking, and hyperlipidemia. And I'll just highlight at the time that compared and were slightly different from the 2005 AASLD guidelines. So thinking again about our second case, our liver transplant candidate with multiple risk factors, what are the testing options available for further risk stratification and how good are these modalities? In 2019, there was a study that looked at dobutamine stress echo in this patient population. And I will say at the outset that there is a referral bias in using dobutamine stress echo, and we don't use it much here at BIDMC for this particular purpose. But that being said, of the 633 patients that were evaluated, there was an overall low prevalence of coronary artery disease, but the sensitivity of the dobutamine stress echo was 24% overall. Specificity was higher at 90%. They did also stratify by coronary disease risk, and the sensitivity went up to as high as 32% in the highest risk. And so overall, as well as in the 2012 guidelines, perfusion imaging as an alternate option was thought to have low sensitivity overall in this particular patient population, specifically as it relates to their sort of baseline vasodilated state, making the use of vasodilator agents more limited. And often these patients are more debilitated and often can't walk on a treadmill. And so again, this led to class 2B recommendations that are somewhat vague and say that non-invasive stress testing may be considered in this liver transplant candidate with no active conditions. And they suggested using the cutoff of 3 risk factors, but left that open to interpretation due to the lack of data. And so that brings us to 2017, where we found ourselves as a multidisciplinary group coming together again to improve the risk stratification approach to compensate for all of the limitations in testing modalities and the allocation, taking into consideration the allocation of this scarce resource in a relatively sick population. And that led to the acknowledgement that coronary anatomic assessment was needed to better define cardiovascular risk in the highest risk patients. So on the left here, you can see our initial protocol for kidney transplant candidates with a fairly low threshold for diagnostic angiogram for patients with known CVD, CAD risk equivalents, or multiple risk factors. And similarly, on the right, for the liver transplant candidate, this was the initial guideline for who should be considered for angiogram, even after stress testing. And so while this initial approach certainly had potential improvements over stress testing alone, and did focus the work to a dedicated group of cardiologists who could work closely with the transplant teams. The question remained, could we find a way to refine a patient's true long-term cardiovascular risk with an anatomic assessment while also minimizing the risk, albeit small, of a diagnostic invasive procedure like an angiogram? In trying to answer that question, a group from Denmark in 2018 published findings on the use of coronary calcium score and coronary CTA and use of risk assessment in kidney transplant candidates. And I'll just mention that patients both on dialysis and not on dialysis were included in the analysis. And in the study, the patients had an extensive risk factor assessment. They had a calcium score performed, coronary CTA, a SPECT study, and a diagnostic angiogram performed. And there are a number of other findings that we're going to focus on in different sections of our talk today, but I'll just focus today and draw your attention to the two top panels here, A and B. And panels A and B show that the 2-year prognosis, that is the rates of MACE on the left and mortality on the right, in patients with advanced CKD without stenosis on coronary CTA were excellent. And so that's represented by the green line and included about 50% of the cohort. And so in 2019, we came again together and included our radiology colleagues and revised both protocols to incorporate coronary CTA along with CT-FFR for the most high-risk patients instead of coronary angiography. And so here is our updated kidney transplant algorithm. And we also did the same for the liver transplant candidate algorithm as well, and made it easier to follow, as you can see. And with the hard work of one of our former fellows, Dr. Donia Mohabali, we published our standardized protocols incorporating coronary CTA, which was relatively novel at the time. And so just to close things out, returning to our cases, in case 1, if you remember, this candidate had multiple risk factors on hemodialysis, no anginal symptoms, and a normal perfusion study. And she ultimately was referred for a coronary CTA seen here on the left, and clearly has a high burden of coronary disease. You can see it here in a still frame with a very high calcium score. And how we address managing these findings on CT will be discussed in the next section. Lastly, our liver patient who also had multiple risk factors, including diabetes. In our initial iteration, if you remember, would have been referred for a diagnostic angiogram. However, with our updated protocol, he underwent a coronary CTA shown here. And here's the RCA, LAD, and the left circumflex. And overall had a calcium score of 0 and no plaque or stenosis. And so given these results, we were able to refine his overall cardiovascular risk to a lower risk category and avoid an angiogram in this patient. Thank you very much for your attention. Now I'm going to pass it off to Dr. Fraiche to pick up the story.
All right, thank you so much, Anne-Marie. So by the time patients reach the cardiology clinic, not only is it usually their 3rd appointment of the day, but they've also often had 1 or 2 of these diagnostic modalities as part of the most recent iteration of our transplant protocol. So we spend much of the visit trying to better understand sort of their traditional and non-traditional risk factors for coronary artery disease, as well as reviewing whatever testing they've had, and then talking about maybe any additional testing they may need to further understand that risk, and explaining any recommendations based on that. So we've talked about the potential benefits and limitations of several of these testing modalities, but I now hope to expand upon that, particularly for some challenging scenarios within this complex patient population, and demonstrate how we integrate these diagnostics into our evaluation and treatment plans. So this slide shows our current protocol, which you can find on the PPGD from the portal. And as you may recognize, this protocol is not significantly different from that which was shown previously, with the inclusion of coronary CTA, as shown for patients on hemodialysis or advanced liver disease without CKD. The inclusion of coronary CTA has really streamlined the process, whereas one of those tests I mentioned previously that they may have had prior to even meeting one of us is a coronary CTA. And for example, the results of that test may lead to them not even needing to CS, because they may have a coronary calcium score of 0 and have no coronary artery disease and need no additional ischemic evaluation. Or it may show non-obstructive disease, and this information could be fed back to the primary care provider for consideration of medical optimization, such as statin therapy, with a slight also note from the liver team about the safety of statins in patients with liver disease, as well as the monitoring, so that it can help with any hesitancy regarding starting that therapy. So that means that we're really only seeing among the patients who qualify for coronary CTA, the highest risk individuals. So after 3 years of experience performing coronary CTA in patients on hemodialysis with or without renal insufficiency, more recently, we've tried to figure out what to do with the patients who are not on hemodialysis, who may be on peritoneal dialysis and still have some residual renal function, or liver transplant patients with some degree of renal function impairment. So why are we more cautious with contrasted studies in these patients? We really can't get through today's talk with at least mentioning contrast-associated or contrast-induced AKI. This is also known as CIN or contrast-induced nephropathy. So I just briefly wanted to highlight sort of the complexity of the understanding regarding this and the several mechanisms that are proposed, really, related to the cytotoxic effects on tubular epithelium and/or disturbances in renal blood flow that may further impair renal function in chronically diseased kidneys when renal hypoperfusion may already be at play. The reported incidence of contrast-associated kidney injury varies wildly among different studies, really based on differing definitions of contrast-associated AKI, as well as different patient populations. So on the left, just for an example, I have shown a patient cohort that involved moderate to severe CKD patients, and that showed a 14% or near 14% incidence of contrast-associated AKI. I didn't show this to talk about the difference or the lack of difference between sodium chloride or sodium bicarb in terms of peri-procedural hydration, but just one example of an incidence. But some limitation to a study like this, because really only 20 patients in this entire cohort had a GFR of less than 15, which may be similar to a lot of the patients that we're seeing. On the right-hand side, this is taken from the ADEPT drug-eluting stent trial, which was a multi-center trial related to drug-eluting stent implementation and platelet reactivity. I'm not talking about that today, but there's a post-hoc analysis of that trial for patients who had a baseline creatinine on the day of admission and then a creatinine 3 days later. And contrast-associated kidney injury was actually defined very similarly to the trial to the study on the left side. And it was notably found that patients with baseline CKD, there was an independent predictor of contrast-associated AKI, and contrast-associated AKI was found to have a significant prognostic impact in patients undergoing PCI. As you can see, patients with CKD and contrast-associated AKI had a much higher rate than net adverse clinical events. Second to that were patients on dialysis. Now, there's major limitations to this. We don't know how much contrast was used, and we don't really know or able to understand sort of what happened to the renal function after that time. Was there, any implications on the, did it recover or did it significantly worsen, and how that affected net adverse events. Finally, I just want to make note of a term that was coined 20 years ago that I learned recently called renalism. And this was the idea that was described as an alteration in clinical practice, just about the sort of fear of developing contrast-associated AKI in patients with CKD. And so in this study 20 years ago, they saw that patients roughly half the time that had an indication to go forward with cath did not go forward with cath for patients. And it showed that there were worse outcomes in the patients who did not undergo the catheterization. So I'd like to illustrate this dilemma with a case. We have Marie, she's 65 years old. She has CKD5, she's not on dialysis, and she has hypertension and several other risk factors for ASCVD, mixed dyslipidemia, prediabetes, obesity, family history of premature coronary artery disease, and is a former smoker. She walks regularly and does not have any anginal symptoms. And her cardiac testing prior to referral includes a normal echo and a normal MIBI. So if we just plugged her into one of the typically and more commonly used risk calculators, like the pooled cohort equation, she would come out with like a measly 4.5% risk, which we know would clearly underestimate her cardiovascular risk in light of several risk enhancers, and notably as discussed about advanced CKD. So I want to also highlight that this program is not just designed to evaluate this risk, but also to potentially recommend therapies or begin to modify that risk. So based on the protocol prior to this year, we would plug her in to the protocol, and based on 3 or more risk factors and a normal stress test, she would end up being referred to us for consideration of angiogram. Now, what that would look like is that we would defer it for now because she is not yet on dialysis and does not have an identified donor. So taking that a step further, while waiting for a study requiring contrast, the patient remains temporarily inactive or status 7. accruing wait time, but not open to offers. And offers can come at any time when a patient is actively listed, but increase the longer someone is listed. A patient listed pre-dialysis may actually not need dialysis for many years, and so they're accumulating wait time, but they may not be able to be transplanted because they're not open for offers. But we know that preemptive transplant prior to dialysis is associated with better outcomes. So ideally, we would have more patients actively listed pre-dialysis and able to receive transplant offers during that time. But we're weighing this balance with the risk of contrast. So finally, for the institution, more actively listed patients mean more offers accepted at BI and more transplants, which is also great for the institution. So we hoped we may add another tool to better risk stratify these patients who may be able to avoid dialysis and get transplanted sooner. And we recognize that the use of calcium score at other transplant institutions, and we also recognize its wide use in preventive cardiology. And we hope that maybe we could identify a lower risk group of asymptomatic patients that may go further testing and contrast risk. But we still had to ask, how does calcium score perform in pre-renal and pre-liver transplant patients? So back to the study that Anne-Marie referred to earlier, it's because we refer to this twice during this talk, is because it's one of the few randomized prospective trials we have that referenced coronary CTA, or that we referenced for coronary CTA inclusion. And so we sought to better understand the results of the calcium score component. As mentioned before, there's 154 patients in this study, and about half of the patients were not on dialysis, with a mean follow-up of 3.7 years. So in terms of numbers of patients with calcium score, about 26% of the patients actually had a score of 0, around 43% had a moderate score, and 30% had a score greater than 400. In a time to event analysis, both risk factors and calcium score significantly predicted death, but only calcium score predicted MACE. And the MACE included sudden cardiac death with resuscitation, STEMI, NSTEMI, and all-cause mortality and revascularization. So using a calcium score of 0 as a reference, a time to event analysis showed that a calcium score greater than 400 was associated with MACE and mortality, but a calcium score 1 to 399 was not. And two groups to highlight include a group with less than 3 risk factors with a calcium score of greater than or equal to 400, and this group with greater than 3 risk factors with a calcium score of greater than or equal to 400. And these two groups had significantly increased risk compared with patients who had less than 3 risk factors and a calcium score of greater than 400. So this is just one study we wanted to highlight, but there are other studies that have also looked at calcium score in patients, in CKD patients, pre-dialysis, and have shown some improved risk prediction over risk factors alone. So turning to the liver population for calcium scoring, in this single center retrospective cohort study, there were 431 patients who underwent liver transplant with calcium scores calculated prior to the transplant. And regarding the outcomes, they saw 4.62% increased risk of cardiovascular complications when the calcium score was greater than 400. Notably, only 2.5% of patients had a calcium score greater than 400, and only 1% of the patients in the entire cohort were on a statin. So now to introduce the protocol from 2022 that features calcium score. With this, we hope to identify some low-risk patients who do not need a coronary anatomical study to be listed. And I do want to highlight, we're using this now, or we're starting to use this to consider for patients with liver transplant evaluation with some indicator of renal function impairment or not on hemodialysis. And some major limitations that we're still trying to work out include specifically cost, because this is rarely covered and the out-of-pocket cost may be prohibitive for many of our patients, and unclear warranty, and that they still may need invasive testing. So back to our patient with a calcium score of 107. We decided not to pursue angiography or wait any longer for her to end up on dialysis or to do a cath, and so we decided just to pursue medical optimization. So shown here again is the protocol highlighting calcium score and how it's now integrated into the protocol for higher risk for our patients. And we are now able to identify a lower risk patient. We're able to identify patients in the mid-range who may be referred back to the PCP for consideration of medical optimization. And we are now able to see the patients again who are higher risk to consider additional testing. I wanted to mention that anyone with any anginal symptoms sort of bypasses all of this and comes to us hopefully for further ischemic evaluation. So now what does that look like? We've discussed the approach to screening for asymptomatic coronary disease, but I want to turn to optimization and complex decisions surrounding revascularization. We know this practice varies wildly among different transplant centers, and we hope to highlight that in our practice, such therapy is reserved for high-risk anatomical subsets. So we do continue to perform invasive angiography for patients who have higher risk of significant disease. So a few key points to highlight during this section is that our timing is really, really thoughtful when we decide to approach this invasive testing, and we don't just send patients immediately. We're talking to the primary nephrologist, the transplant nephrologist, and the transplant team in general, and we're really trying to decide when is the best time to do this. Again, as mentioned, patients with pre-transplant are very underrepresented in trials related to coronary revascularization. And I have to make a nod to the CAF team, the interventional team, and their strategies to reduce the risk of contrast-associated AKI, including at the time of PCI with ultra low and very low contrast PCI. And that the decisions regarding when to revascularize in these rare situations is based on a team approach. So getting back to case 1 from earlier in the talk, this patient was found to have significant proximal LAD stenosis on the coronary CTA. This was confirmed on CAF, as shown here, and she undergoes successful drug-eluting stent placement of that proximal LAD felt to be high-risk anatomy. So part of the reason of why that maybe decision was decided at the time was also because we have a few guidelines to help us. Actually, at the end of the 2017 stable ischemic heart disease guidelines and revascularization guidelines, there is a nod to patients who are undergoing renal transplant evaluation. And as you can see, I've highlighted here for a patient like this with including proximal LAD stenosis with low risk, non-invasive findings, there's a yellow, so it means that this may be considered. I want to just juxtapose this very briefly to one other patient who has end-stage renal disease on hemodialysis undergoing transplant evaluation, is hypertensive diabetic, and has some mild dyspnea at 30 minutes of strenuous activity. He has a normal NIBI, his cardiac meds are beta blocker, statin, and aspirin, and he gets a coronary CTI showing 2-vessel coronary disease, including a heavily calcified, flow-limiting mid-LAD lesion. And his catheterization is shown here. So again, from the 2017 appropriate use criteria for coronary revascularization and stable ischemia, you can see here I've highlighted what he would where he would fit into this category. And this is sort of very variable, right? And so there's red, you can see that would be rarely ever indicated. There's some yellow. And so this is really a more challenging kind of nuanced situation, really based on symptoms and medications. And what other support do we have to guide this decision? So as many of you may know, we now also have the results of ischemia CKD, which includes 777 patients with advanced CKD with a GFR less than 30, and about half of the patients were on dialysis and half were not. In the invasive strategy, CAF was performed with revascularization as soon as clinically appropriate, and the decision to revascularize was left to the clinical team. There was also protocols about low contrast, hydration, and zero contrast PCI as well. And in the conservative arm, CAF was really reserved just for patients who failed medical management or had ACS or heart failure. And regarding the results in the invasive strategy, only 50% had an intervention, and there was no difference in death or MI, nor an improvement in angina in those patients. We also had the results reported from ESC recently with the extend part of the ischemia CKD trial with the 5-year mean follow-up for the primary endpoint of death. And there are an additional 113 deaths after the original results were published, with a total of 305 deaths now. And there was no significance, again, between the treatment groups. There was also, that indicated a 40% mortality for the patients in this trial, which a lot of that was due to cardiovascular. Furthermore, there was a sub-analysis of the patients who were undergoing transplant evaluation within ischemia CKD with the primary outcome of all-cause mortality and non-fatal MI, and there was also no significant difference in the treatment groups. And about a quarter of those patients went on to receive transplant. So back to our patient, that we described, we decided to medically manage and to not revascularize. And he's doing very well a year and a half later on medical management. So now I would like to turn it over to Mike to bring us home.
Just the camera here a little bit. All right. Okay, thanks, Coco. I do want to just take 1 second to acknowledge the work that Coco and Anne-Marie have really done with this, with all of this work. I see the vast majority of the patients now. It started these efforts with the transplant and nephrology and renal liver groups years ago, as you just heard about. But they have really taken all of this work forward. And in addition to their efforts, I'd want to highlight some of the work that our fellows have done, given this a fellowship application day, and reviewing some of this data and opportunities for further research in this area. So Killian McCarthy is one of the interventional fellows, general fellow, also my clinic fellow. And Daniel Calderon is now a resident down at Vanderbilt, had come to us through the International Research Initiative through Harvard and Harvard School of Public Health. They look back at our liver transplant population from 2016 through, at that time, end of 2019, which encompassed really the two initial protocols, the first rolling out at the beginning of 2018, and then the second in the beginning of 2019, incorporating CT to see what had evolved in terms of utilization of testing strategies. Donia here, as Anne-Marie had mentioned, she had written up the initial description of these two protocols in cardiology and review, and she's now at Intermountain Health, had done a heart failure transplant fellowship at Cedars-Sinai. But as we discussed, prior to 2018, really, the evaluations were done on an ad hoc basis. Almost everybody was getting a nuclear perfusion study with any risk factors, but there wasn't any formal protocol leading to cardiology evaluation. In 2018, we then shift to patients with more than 3 risk factors or a coronary risk equivalent, getting a nuclear perfusion study, but also meeting with cardiology, with really the primary question being, should we move to anatomic imaging, coronary angiography for further evaluation for all the reasons that have been discussed. And then in 2019, of course, we incorporate CT in an effort really to reduce the number of invasive studies that need to be done with the accompanying risk. And so the goal is to look back and see what happened over the course of those few years. The population, as we see here, is enriched in traditional cardiovascular risk factors, hypertension, 37%, diabetes, a quarter of this liver population. And that speaks to the rising incidence of NASH as the cause of cirrhosis and need for transplant. In this group, 14%, but that's a number that's continuously rising. So what do we see? Well, the cardiology consultation use of consultative services increased dramatically prior to the protocol, and then during the protocol from 24% to 40%. And then when the CT gets incorporated, because that would allow these 3 risk factor or even diabetic patients to bypass consultation with a low-risk CT, as Coco just discussed, did then drop, not surprisingly. With this, CT use rose quite significantly from 30% 6 up to 26%. I'll show you some more recent data around that. And invasive angiography doubled essentially from pre-protocol to the 2018 protocol. So the use of invasive angiography, while not for the majority of patients, did increase significantly. It decreased a little bit with the introduction of CT, but for some reasons, I'll show you in the next couple of slides, it doesn't decrease dramatically. Essentially, it's flattened out. And then more importantly, then you look back and say, well, if you're investigating more deeply, are you rendering more patients ineligible for transplant on the basis of identifying coronary disease that may or may not be revascularizable? And in fact, the percentage of patients being evaluated who go on to listing continually rose. So we're doing a more intensive evaluation, identifying opportunities for medical management, collaborating with the transplant teams, and actually listing more people with no change in cardiac-related complications over that time. Our protocols, while they seem quite rigorous, really result in fewer angiograms and some of the other more widely publicized, some of the other protocols that are published in the literature. So Indiana University has a large cohort, and in their group, 71% of their patients being evaluated are undergoing invasive coronary angiography. This is liver specifically. And for us, we're only looking at 17%. So pretty dramatic difference. And similarly, with the rates of revascularization, we were only at 1.5%. They were at 14%. Reassuringly, if you look at the MI rates in the first year post-transplant, very low. In fact, in the time period up through this slide was 0% for us. And then the percentage of patients being listed relatively similar. In their group, actually, any patient with 1 risk factor in this list here does undergo invasive angiography, so more intensive than our protocol. So we've looked at also, Rachel Kirkbride is a radiology fellow, so now collaborating with radiology opportunities there. Mark Tuttle was an general and interventional fellow with us, and is now in practice. And Mark reviewed the angiograms, Rachel reviewed the CTs of both liver and kidney transplant patients. 162 CTs. Not surprisingly, the kidney group had poorer imaging than the liver group. Heart rates tended to be higher, more calcium, more movement. But at the end of the day, most studies were diagnostic. And I think the important piece to point out here is that, one, we do identify a lot of atherosclerosis. You're looking at 44%, 40 to 44% of patients with coronary artery disease, athero, that we didn't know about in most of these, as the case is demonstrated with normal nuclear perfusion studies. So opportunities for instituting medical management for atherosclerosis, which is incredibly important. We know from the PROMISE trial and from the Scott Hart trials that if you look at the patients getting CT, outcomes do seem to be better, likely because of increased utilization of medications like statins, maybe aspirin, but probably lifestyle as well. The one thing that's important, and this is seen through other CT, across the CT literature really, is that while we identify a lot of athero, it overcalls a severity of stenosis. So the discordant cases had stenosis overcalled almost exclusively. So where do we stand now? Some different numbers. On the left was from the radiology, on the right is from the transplant group. I think you focus on the numbers on the right, really progressively increasing utilization of CT-based imaging, both calcium scoring and coronary angiography, dramatic increases over time, a lot of it in the liver group and the kidney group, again, because some of the challenges with imaging quality actually is a little bit lower, but that's also increasing. Drop off in 2022, not surprisingly, was in the face of one, there was a major contrast shortage. So that was a production issue in China. There's staffing troubles, which is across all of the medical workforce. Our scanner was down for a while. We're also using cystatin C to identify more subtle renal dysfunction that was excluding some of the patients. But those are probably some of the reasons we saw a drop off in 2022. Now, what about consults and utilization of the cardiology services? This is looking calendar year 2019 through calendar year 2022 to date. And if you look at the cardiology consultation numbers across liver and kidney, they're running about flat, if not increasing slightly. And so while we're introducing CT, I think with the multidisciplinary approach here, we're still seeing about 3 consults per week. And among the patients, the percentage of patients who are being evaluated, we're seeing about a third to 40%. This year, 45% of the patients being evaluated are seeing one of us in cardiology. So it's a large number of people, presents an opportunity to really study these protocols. And as I mentioned before, what's important is that the light blue is the listings. So listing numbers have gone up. So the evaluation's relatively flat, but we're listing more people, getting them through the pipeline. And so where do we stand in terms of opportunities looking forward? One of the questions is, this calcium score of 400, how does that work, or how does that correlate really with obstructive disease? So are we going to undercalling obstructive disease or missing people? So that's an active area of investigation. And then, just to point out that we really, part of this program, this multidisciplinary program, is not just looking at coronary disease. It was the focus of the talk, but we're seeing patients with hypertrophic cardiomyopathy, valve disease, aortic stenosis, prosthetic valves, you name it. It's all part of the evaluation. And the effort really involves everybody from the call centers to the CT techs, the sonographers. In order to get people through this system, it requires a huge effort, and the pipeline can kind of get clogged at any point along the way. So working together is really been one of the joys of this, to help move both the cardiology investigative aspect of it forward, but also get these patients to their life-saving therapies. So many people to thank listed on this slide, and maybe we'll stick around. I know there's interviews, but happy to take any questions. Thank you.
Thank you so much to all 3 of you. Those were fantastic. I think we have time for one question. We had one question come through the chat, but I think you essentially answered that just now, Mike. So we have a question from Dr. Ernie Gervino, who says, great talk. Is there a clear preference for one modality of testing at BI, understanding the various limitations due to the nature of the patient population and the resources? And I think we'll end with this one question.
Well, when we're doing functional studies, it's largely been nuclear because of the some of the imaging limitations. Dopamine echo is the sensitivity, as we saw, is lower. It's a little harder to obtain. So largely from a functional standpoint, we're doing vasodilator nuclear perfusion studies as a preference.
Great.
In the protocol, right? But then obviously anatomic imaging taking on a larger role and bypassing that in many patients. So to the fellows, I will say this, as I said, this has really been, I think all of us would speak to this, working with Michael and Martha's groups and Marlon now on the transplant side, the surgery side. It's been a really great experience. And so I think there's a lot of opportunity. It's a really good group of people, and Diana in radiology to work with.
Wonderful. All right, we'll wrap up there. Thank you so much, everyone, to the fellowship candidates. Hope you have a nice day of interviews. See everyone next week.